Welcome everyone to our guest faculty research seminar series. I'm going to introduce our speaker for today, and I think you'll find this an interesting topic as he describes his research. But first, let me introduce Ubaidul Haque. It's an honor to have him here with us today. And Dr. Haque, you've got quite an audience here, and they'll jump in and probably ask you questions after your presentation or maybe even during it. But welcome, and I wanted to describe Dr. Haque. He's an assistant professor in the Department of Epidemiology and Biostatistics at the University of North Texas Health Science Center. And he's committed to diversity, volunteering, teaching, and research, which you'll hear about. His global health research is focused on infectious disease epidemiology in different transmission settings and the relationship between climate change and the deadly landslides occurring around the globe. Dr. Haque has published 87 articles in peer-reviewed journals and secured $1.3 million in research grant funding for the 2 research projects you'll hear about. He's also been a reviewer for numerous scientific journals. He's quite an international academic. He completed his undergrad degree in Khulna University in Bangladesh with a major in urban planning. He received a master's degree in geodesy and geoinformatics from the Royal Institute of Technology in Sweden, and a PhD in public health from Nagasaki University in Japan. He was also a guest PhD student in Norway for a year before now moving to Johns Hopkins University for his postdoctoral fellowship. So Dr. Haque, I welcome you, and I'll turn the microphone over to you.
Thank you, Professor Marlik. Can you see the screen?
Yes.
Yes.
Thank you very much. Let me start. It is my great pleasure to meet with you today. I was born and raised in a small town in Bangladesh where I completed my undergraduate degree. My master's was from the Royal Institute of Technology, Sweden, and PhD from Nagasaki University, Japan. As Professor Marlik said, I was also a guest PhD student in Norway for a year before moving to Johns Hopkins University for my postdoc. Currently, I'm working as an assistant professor at the University of North Texas Health Science Center. My research is in global health. In my work, I focus on vector-borne diseases in different transmission settings and understanding the relationship between climate change and deadly landslides at the global level. I'm a special disease modeler and use geographic information system, remote sensing, and different statistical software. Today, I would like to share how I have applied these tools to investigate malaria epidemiology in Bangladesh. Before moving forward, I'd like to give you some brief update about global malaria epidemiology. There are 87 malaria endemic countries, and half of the world's population are living at risk. Approximately 241 million cases and 627,000 malaria-related deaths were reported in 2020 from all over the globe. Although malaria is known as an African disease, few countries in Asia and Latin America are highly endemic. Now, I will take you to Bangladesh, where malaria is a major public health problem. From the late 1990s, approximately 300,000 cases were reported each year. Clinical diagnosis was common until 2007, and the unreported cases were completely unknown. In Bangladesh, 13 of 64 administrative districts have an endemic malaria transmission. 8 of these endemic districts are in the north of Bangladesh, sharing a border with India, and 5 districts are in the southeast of Bangladesh, sharing borders with India and Myanmar. A cross-sectional study in 2007 reported a 4% prevalence in these endemic districts. More than 90% of the cases were Plasmodium falciparum, and the highest prevalence was reported in 3 districts in southeastern Bangladesh known as Chittagong Hill Tax. We used a Bayesian geostatistical logistic regression model with environmental covariates to predict Plasmodium falciparum parasite ratio to distribute the limited resources. From this map, we calculated approximately 6 million people are living in areas where the risk was more than 0.5 to 1%. 3 million people are living in areas where the risk was more than 1 to 5%, and 0.7 million people are living in areas where the risk was more than 5%. From this cross-sectional study, the highest prevalence was reported from Rajasthali sub-district, mostly the home of 24,000 Aboriginal people, where people have very limited idea about modern civilization. This hilly area is covered with forest, lakes, and streams that made an excellent breeding ground for malaria vectors. It is an I became interested, and in January 2009, I started a longitudinal study there for the next 3 years. In 2007, the Global Fund approved $39.8 million to support the Bangladesh National Malaria Control Program. Using this money, the control program distributed long-lasting insecticide-treated bed nets and started to provide early diagnosis and treatment at a community level. I tried to investigate if people are really taking this free diagnosis and treatment from the control program. At the beginning of the study, we went to mountainous villages, collected baseline information, and mapped 5,322 households, all community health workers, health facilities, and drug vendors locations. Household had multiple treatment seeking options. 67% household preferred control program with proper diagnosis and treatment. 49% household preferred drug vendors without a diagnosis. 23% of households exclusively preferred drug vendors without a diagnosis, and 2% of households prefer traditional healers. We calculated the distance from each household to all health facilities, community health workers, and drug vendors locations, and access the associations between the charge of treatment and the distance to different treatment sources, education, occupation, and ethnicity. For your kind information, the system in Bangladesh is not like the United States. Anyone can go to pharmacy and buy any drug without a doctor's prescription. People do not prefer control program if it is far from 2 kilometers, but still prefer drug vendors when it is more than 2 kilometers from their home. Education was associated with preferences for the proper diagnosis and treatment. Some of these factors were associated with ethnicity. From this study, we concluded treatment from vendors without a diagnosis may cause incomplete treatment, misuse of antimalarial drugs that may contribute to the risk of drug resistance, and may jeopardize the present malaria control efforts in Bangladesh. From the last study, we realized despite the availability of community health workers, a large portion of households are not taking free diagnosis and treatment. Now we try to find a solution through geospatial modeling. The spatial patterns of treatment seeking practices are examined using hotspot analysis. These statistics determines whether the differences between the rate for a village and its nearest villages are significantly different from the rates for all villages. A statistically significant positive G-score indicates a hotspot for high rates, and the negative G-score indicates low rates. Hotspots for vendor users are strictly restricted in the Western region, and control program users are centered around the largest hospital. We used 88 explanatory variables that might be a predictor of treatment seeking behavior and run in the ordinary least square regression model, but results from the ordinary least square regression analysis can only be trusted if coefficients for model explanatory variables are statistically significant and have the expected sign. Free from multicollinearity, residuals must be normally distributed with a mean of 0 and free from spatial autocorrelation. Here we got one properly specified OLS model for vendor users. Villages far from the regional hospital with very little schooling and fewer homes constructed using star roofing materials, which is an indicator of better economic status, are more likely to prefer vendor services. Since our previous model passed in ordinary least square regression analysis, there is a chance to improve it in geographically weighted regression analysis. Here we got better AIC and R-squared value in the GWR model and finally improved it. Distance to the regional hospital and village size had a positive relationship with a preference of vendor services. This figure, obtained from the geographical weighted regression model, shows this explanatory variable is a very weak predictor in the easternmost villages, where the coefficient is nearly 0 and even slightly negative. But it is a strong predictor throughout the rest of the area. The darkest color and larger coefficient indicate a stronger relationship. Provide some training among community health workers or awareness campaign among these particular villages may change treatment seeking behavior. As the number of household head with no schooling increased, preference for treatment from a vendor also increased. This figure, obtained from the geographically weighted regression model, shows the coefficient for the education variable is the largest and a strong predictor in the western villages. Some education in these particular villages will be helpful to change the treatment seeking behavior. As I mentioned earlier, 36% malaria prevalence was reported from this area in 2007. Meanwhile, several interventions were introduced to control malaria. Now we became interested to know whether prevalence remained the same after 2 years of intervention program. We carried out another prevalence survey in 2009 and found a 12% prevalence. Malaria has significantly decreased within 2 years after the onset of an intervention program. Like before, more than 90% of the cases were Plasmodium falciparum. 3 statistically significant malaria clusters were observed. We also created a land use map using satellite images and checked if any particular land use category within 2 kilometers of houses were a predictor of malaria risks. The risk of malaria infection in males was higher compared with female. Children are more vulnerable than adults. Having 2 or more bed nets was protective against infection. Increased forest coverage within 2 kilometers from household proved to be a significant risk factor. People living at higher altitudes are more vulnerable to infection, and the higher density was associated with increased risks. So far, all we did are cross-sectional studies. Now to understand the epidemiology, risk factors, and progress in a much better way, we used longitudinal data collected from January 2009 to December 2010 for malaria incidence in 54 villages in this study area. We investigated bed net ratio per household, housing construction materials, hydrological and topographic risk factors, and special patterns of the disease over 2 years in the same population. We used 30-meter resolution digital elevation data from the United States Geological Survey and created a STModer network, extracted topographic wetness index, aspect and elevation for all 1,634 houses. 497 malaria episodes were recorded from 7,992 individuals. 78% of households did not experience any malaria. 16% of households reported one infection, and 6% of households reported multiple infections. Malaria hotspots persisted during the 2-year study period. 120 particular households appeared in significant clusters in both consecutive years. Malaria incidence was highly heterogeneous between villages. In 2009, 2 statistically significant malaria clusters were observed. In 2010, 5 such clusters were detected, where observed cases were significantly higher than the expected cases. We use SATScan software and multicolor simulation method to detect special clusters. Malaria was associated only with having less than 1 bed net for every 2 persons per household, living in a house made of mud walls and house density. Once again, we concluded not only malaria cases, risk factors also decline in this study area. Now, I want to summarize this part. My previous studies reported malaria decline in this study area. Interventions used among marginalized populations, households received long-lasting insecticide-treated bed nets, and persistent malaria hotspots are observed. We also noted progress in disease mapping. Please let me know if you have any questions so far.
Dr. Hay?
Yes, please.
So on the geo mapping like that of households, is there involvement of the households in giving any permission, or is it, how's that set up with the IRBs or those sorts of things in terms of households? I asked because in HIV work, we're in African settings and certain large villages or other settings. That obviously a big issue of confidentiality of who's living with HIV in the household when doing mapping.
No, actually, I took IRB and I took the consent of the household before we started this study. So it was
Okay.
not an issue there. Yes, some households declined to participate, so we did not take. Yeah, they were not included in this cohort study.
Stefan?
Yeah, hi, Dr. Hack, thank you very much. Quick question regarding the hotspots that you observed. Now, from a public health point of view, the most reasonable approach would be now to focus prevention efforts into these areas. Is that what you're going to do with your data now? Or
Sorry?
will you? Oh, so the significant malaria hotspots that you observed would now allow to focus prevention efforts onto those areas, right? You could now go into these areas and do specific interventions, such as vector control. Is that a plan that you have? Or do you work with people who can execute such ideas?
Right. We then shared the result with the government. So the government came, the National Malaria Control Program and their partners, they came with more bed net, they came with more diagnosis, they came with more treatment there. And they deployed some of their health workers to take more preventive actions.
Yeah, yes, okay. I mean, you said people used nets, right? And despite of that, they get very much infected. What is there something wrong about that idea of that bed nets do the job, or what else could be done?
Sometimes some people use their bed net for fishing. You know, probably that is a common practice in many parts of the world. Sometimes still I showed that treatment seeking approach was very different because people behavior change is very difficult. So people used to take drug from the vendors without doctor's prescription, although they did not have malaria sometimes. In that part of the world, when people get sick, people always take antimalarial drugs. In general, since that is a highly endemic area, people always believe that they can go to pharmacy and they can buy a drug because sometimes traveling to 2 kilometers is very tough for them to get a diagnosis, free diagnosis and treatment, whereas they can go to pharmacy and buy antimalarial drugs. That is another issue, but the cases declined. Hotspots exist in any surveillance system. If you use the data for analysis, you will get some sort of hotspot as long as the cases are there. So hotspot exists, but cases significantly declined.
Thank you.
Any more question, please?
Hello, Dr. Huck. Thank you for your great talk. I think it was the slide before this current one, where you talk, yes, the density of the households. So can you explain why like the 500 to 1,000 was not significant? Because it looks like anything that's more dense would be associated with higher rates.
500 to, right. It is that area, you know, that population are distributed, households are distributed in a scattered way.
Okay.
It might be vector. I don't know. I talked with entomologists during that time,
right?
But they failed to come with any idea why that happens. But that kind of result also published from Nigeria and from some other countries that household density is a risk factors in the case of malaria distribution. But I think the entomologist can tell much better. But during that time, I was consulted with an entomologist, and then they said that density is a factor, but we don't know why that particular number is a matter.
Okay, so basically we don't know the tipping point at which it becomes significant.
Right.
Okay, thank you.
You're welcome. The Global Fund donated $39.8 million to support the Bangladesh National Malaria Control Program from 2008 to 2012. The goals were to reduce malaria morbidity and mortality, provide diagnosis and treatment in hard-to-reach areas, and provide long-lasting insecticide-treated badness. Published studies suggest malaria decline in Bangladesh, but a systematic evaluation of the impact of the program has never been conducted. Both donors and policymakers should have information on the cost and benefits of interventions. To address this gap, we performed an epidemiological and economic evaluation of malaria episodes' total cost and disbursed funds from 2008 to 2012. We also created malaria maps and compared international donor assistance for malaria control in Bangladesh with other endemic countries. Passive case detection at hospitals and rapid diagnosis at the community level by community health workers are the main methods of malaria surveillance in Bangladesh. Annually reported, district-level aggregated malaria epidemiological data were collected from Bangladesh National Malaria Control Program. Data are also available on the number of long-lasting insecticide-treated bed nets each year at the district level. Detailed data on funds given to Bangladesh National Malaria Control Program were collected from the Global Fund and Bangladesh Ministry of Health. We also collected data reported in the World Malaria Report 2012 and 2013 about international donor assistance to control malaria in each country and their total populations living in malaria endemic areas between 2008 to 2012. A district random effect model using partial regression analysis was used to explore the associations between total malaria, severe malaria, malaria-associated deaths, and long-lasting insecticide-treated net coverage in 13 endemic districts. District-level malaria prevalence in 2008 and changes in subsequent years was separately mapped and analyzed for a special clustering. We performed a cost-effectiveness analysis. Only 14 million people living in malaria endemic areas in Bangladesh are used as the denominator. We also calculated each malaria endemic country's per capita investment from international donors. From 2008 to 2012, nearly 285,000 confirmed malaria cases were reported in Bangladesh. During this time, Bangladesh National Malaria Control Program performed 2.2 million tests for malaria diagnosis. 56% cases were confirmed by rapid diagnosis test and 44% cases were confirmed by microscopy. Approximately 90% of malaria cases were Plasmodium falciparum, whereas Plasmodium vivax and mixed infections were 10% and 0.4% respectively. Bangladesh also achieved one long-lasting insecticide-treated net coverage for 82.6% in 13 endemic districts. There was a sharp decline in malaria prevalence from 6.2 cases in 2008 to 2.1 cases per 1,000 population in 2012. Considering 2008 as the base year, total malaria, severe malaria, and malaria-associated mortality declined by 65%, 79%, and 91% respectively in 2012. A decreasing trend in malaria was associated with long-lasting insecticide-treated net coverage. Districts having more than one LLIN for every 2 persons were associated with a reduction of 91% total malaria, 25% severe malaria, and 76% malaria-associated mortality on an average from 2008 to 2012. Look at this figure for a minute. It is reporting about changing transmission of malaria patterns from 2009 to 2012, considering 2008 as the base year. 3 districts in the Chittagong Hill Tracts and Cox's Bazar reported malaria hotspots in 2008. There was a continuous reduction of malaria cases in all endemic areas in the northeast and Chittagong, Khagrachuri, and Rangamati districts in the southeast of Bangladesh until 2011. The number of malaria cases reduced in all 5 districts in the south, Kurigram and Mameshing in the north, Moulvibazar and Hobiganj in the northeast of Bangladesh in 2012. From January 2008 to December 2012, Bangladesh National Malaria Control Program spent $44.7 million. 49% donation came from the Global Fund and 11% from Bangladesh Ministry of Health. The per capita yearly average investment to control malaria was $0.41. Bangladesh National Malaria Control Program spent $0.39 per diagnosis, $0.51 per case treatment, and $0.68 per person per year long-lasting insecticide-treated net coverage. Published studies confirm Bangladesh maintained a cost-effective malaria control program, and cost per diagnosis, per case treatment, and per person per year long-lasting insecticide-treated net coverage was lowest in Bangladesh compared with any other endemic countries in the world. This figure reports international donor investment to control malaria. The top figure represents the total population living under malaria risk, and the bottom figure represents per capita investment from international donors. From 2008 to 2012, 87 endemic countries received financial support from international donors to control malaria. Bangladesh ranked 29th, while the highest number of population are living under risk, but Bangladesh ranked 57th in case of international financial recipient from international donors. There are some limitations to this study. It is well known that economic development and urbanization can be associated with reduced malaria burden. In that case, not all improvements in the situation are due to malaria control activities. The number of malaria cases presented here might be underestimated if significant numbers of malaria patients acquire antimalarial drugs from vendors that did not report to the country's national malaria record. Both rapid diagnosis tests and microscopy have limited sensitivity and specificity and are particularly likely to misclassify individuals with low levels of parasitemia. The observed associations between long-lasting insecticide-treated bed net coverage and the burden of malaria are ecologic and not at the level of individuals. The cost calculations also did not consider expired antimalarial drugs, rapid diagnosis test kit, or any other loss in the government stock. In summary, the prevalence of total malaria, severe malaria, and malaria-associated mortality declined in Bangladesh. Increased prevention and control measures were associated with reduced malaria burden. Malaria declined among all age groups. Bangladesh achieved high insecticide-treated net coverage compared with other endemic countries and maintained a cost-effective malaria control program. Historically, the extensive use of all novel antimalarial drugs started along the Thai-Cambodian border has resulted in high levels of resistance in the area, which tends to spread westward through Bangladesh. In recent history, the most novel antimalarial drug, artemisinin, reported resistance in Cambodia in 2007. In 2010, resistance was reported in the Thai-Myanmar border, but no resistance was found in Bangladesh. This study published from Bangladesh was also conducted by Dr. Harold Nodal, who first reported artemisinin resistance in Cambodia. Now, the case for malaria reduction is already sufficiently compelling for Bangladesh. This includes not only the local benefits, but also possibly acting as a buffer against the spread of artemisinin resistance from the Mekong region to the Indian subcontinent. Now, consistent financing is necessary to avoid resurgence and ensure elimination. Long-term financial commitment should not be tied to the reduced malaria burden in Bangladesh. In the next 5 years, I'm planning to work on several topics. I have submitted several grant applications to the National Institute of Health for funding to work on climate change and the spread of dengue fever in Malaysia and Mexico. My study in Mexico will use explainable artificial intelligence to identify the importance of potential drivers of when and where individuals become dengue positive, including demographics, climate, and vector habitat. This study will fill the critical knowledge gaps related to the possible independent effect of each risk factor on dengue fever and serotypes. The second proposal aims to a better understanding of the microclimatic drivers and household context of dengue incidence in Malaysia using the Internet of Things enabled weather stations. Through machine learning and multimodal modeling, the project will develop automated forecasting of dengue incidence and outbreaks. And the third study will develop and evaluate a novel outbreak alert system that will integrate mosquito breeding site monitoring, dengue case surveillance, community education and participation, mobile applications, and aerial drone mapping. This study will fill a critical knowledge gap on the ability to rapidly map breeding sites using a newly developed algorithm based on the drone images as an alternative to field mosquito data collection for dengue risk alert using mobile app. Is there anyone here not familiar with this news? I expanded my research interest and published a special database of deadly landslides for all over the globe. My published study reported an increase in trend of deadly landslides in Europe. It also reported a total economic loss was approximately 4.7 billion euros each year. My second study showed a significant global rise in the number of deadly landslides and hotspots in the last 20 years. This study also confirmed more than half of the events were in areas exposed to the risk of extreme rainfall, which is directly associated with global warming associated climate change. This is completely unexplored field in global health, an emerging problem becoming visible from the end of last century, now happening almost every day somewhere in the world and expanding all over the globe. I'm working with 7 collaborators and applied for funding to the Research Council of Norway and the National Science Foundation of the United States. The proposed longitudinal study design will craft a combination of the stakeholders, citizen scientists, local communities, use social networks such as Facebook, Twitter, and Instagram to implement data collection and monitoring in 8 regions in the world and the most novel machine learning approaches. Thank you.
Thank you. Thank you, Dr. Yeah, Stefan, we should applaud and or virtually applaud. Thank you so much. The diverse areas you've been able to, and will be applying, you know, basically how to monitor disease and our interventions to help across space and across time is very important for the huge areas we've been working on globally in malaria, the other epidemics, and as you said, epidemics or problems related to climate change. So I'm sure there's lots of questions for you.
I'll start in at the end. So I think that the landslide issue is fascinating and really under-addressed probably as a public health problem. So I really applaud that. You have probably had to deal with this from all kinds of different angles, but it would seem to be more pronounced for something like that. The issue of basically reporting, you know, that one person's landslide is another's, you know, just something that happened in the backyard kind of thing. You know, I mean, there are countries that might have resources to really provide that information, media to provide that information, as you showed, and others where it just may be sort of off the radar. Is that something that, you know, there are ways to address and to look forward to think about?
In fact, when I compiled the global database and I communicated with nearly 10,000 people across the globe to bring all the data set, to bring exact locations, I communicated with the geologists, geographers, government disaster department, individual folks, and even I tried to go with the Facebook, those people who put some pictures in the what I call in a Google Earth images, because it was so tough. In many remote areas, those people who live in that particular remote areas, they helped me to compile this database and build this database, clean that. It is true that one landslide just destroyed one village in Indonesia. One landslide killed 5,000 people within 1 hour. So it is, no study was conducted using how it is impacting health.
Yeah.
We are talking about it, we are talking from geological point of view. All geologists are working on it probably in the last couple of decades. But when we talk about health, nothing have done. And you are right that is a backyard problem here in the United States, but that is actually it is collapsing the entire villages. Sometimes one landslide killed nearly 30,000 people. The whole city went to the sea.
Yeah.
In Venezuela. And it is now becoming more and more frequent, but after it is, when it happened, it actually killed people directly, but after that, it has also other impact like nutrition. It is taking the agriculture fields completely down and there is no production. And after that, there are mental health drama, a lot of other issues, and nothing have done so far. That's why we submitted 2 proposals, one to the Research Council of Norway with my European collaborators, and second one was submitted to the US National Science Foundation. We are expecting that the Research Council of Norway will probably go through because that was our 3rd submission. We have exceptional merit and score in that proposal. And that we will bring 8 countries on board in 8 highly vulnerable locations with 8 local partners. So you are right. This is a very fascinating study. I really love that.
Stefan, yeah.
Yeah, thanks again. I want to go back to the malaria piece of your presentation. There were 2 things that caught my attention. Number one, you talked about a changing transmission pattern, and I wanted to find out what you assume are the underlying mechanisms for that. And the other question was that you presented a map where you showed Bangladesh being a buffer against the artemisinin resistance influx. I see how you're addressing the vendor issues, but the vectors, the mosquitoes that transmit the plasmodium are unaffected by that, right? So they come from other places. How can Bangladesh really be a buffer in that way? I mean, it's a vector transmission question rather than a human question, right?
Right. Regarding the changing transmission patterns, we first say the global epidemiologists or the malaria control folks, they say the heat, the hotspot. Let's detect the hotspot, go for intervention and heating the hotspot. So we went for interventions when we found the hotspots. We know that the highest endemic areas in the Chittagong Hill Tax, where the prevalence was very, very high compared with the north. So we went with a lot of interventions there, but hitting the hotspot is not very easy to hitting the hotspot and bringing the cases down. So we, even with the high interventions compared with the lower interventions in the north, it took time. So gradually, as soon as the interventions comes in the north, the cases down there because the cases are already low there. But when the cases are, incidents are very high, both incidence and prevalence are very high in the Chittagong Hill Tax, it took years to change the transmission patterns, to bring it under control, bring it under stable conditions, and bring it under the expected cases. So the transmission patterns changed because of the highly significant interventions compared with the lower endemic areas in the highest hotspots, and in the acting as a buffer, because since the the number of cases already became very low, the cases become under control. So not many people are getting infections in that region. So people need to be infected to get malaria. Since it became under control, since the cases significantly got down, that's why people are not getting infected. Although the resistance is in Myanmar, but resistance, since there are not much cases in Bangladesh control the cases somewhere. So Bangladesh is acting as a buffer. Bangladesh is actually, it is not taking cases from Myanmar. It is preventing cases in Bangladesh, because people in Bangladesh in this part are not getting infected. And in that case, if people in Bangladesh, they got resistance to artemisinin, that will go beyond Bangladesh to other parts of India and Indian subcontinent. In that way, we thought that Bangladesh is actually acting as a buffer to monitor artemisinin resistance.
Thank you very much for clarifying that. Yeah, thank you.
Can you, hi, this is Marila Gennaro. Can you tell us a bit more about the approach that you have in mind, or you have used for, with the involvement of communities and citizen scientists? Because, kind of going back to what Arnold was asking, there is also depending on areas, communities, geographical, areas, etc., there could be a different perception or a different impact overall of certain phenomena. And I think that perhaps the community engagement or involvement could be critical in some of your work.
Yes. In the malaria work, we had the community involvement. We enrolled, in my study, we enrolled 5,322 households. So some of them who got infected, we gave them free diagnosis and free treatment. And sometimes we worked with, not sometimes, all time we worked with the National Malaria Control Program. that those people who did not get bed net, so that they can get the free long-lasting insecticide-treated net coverage. We identified the households who did not get. So in that way, people participated in our study. And in terms of the community engagement, we also put some refreshment. For example, some lunch packet in 2 times in a year. We made them, we did some community program. We showed them what actually the findings we got so far. And we did some kind of workshop in the villages where people came, household head came, they took a lunch packet, they realized what we actually got and how we can be more cooperative with each other when actually we're going for the weekly visit to check whether if any people got infected when our households, when our community health workers, when the project staff visited them to check whether they got fever or not. In that way, we ensured the community participation. We always told them what we got, whether they got positive or negative, whether there any people infected in that community in the last week. So we informed the community in that way. And in case of citizen scientist, in my future applications, we provide some funding for that. The citizen scientists, they can come, they can participate. We put some effort, some percentage of hourly money for them so that the citizen scientists, but it is mostly voluntarily. But we have a plan to recruit 20 citizen scientists for one study area. For example, in Malaysia, they will come and they will participate and they will help in our study, but we will pay them.
Thank you.
You're welcome.
My other question is very similar, just taking a slightly different angle. I know Dr. Marlink's success in Botswana and the work that he did with the local communities there was really based on developing these sort of implementers of the public health in the community. And I presume that that sort of thing is being done. That would seem to be really essential in blocking transmission of something that is so dependent on things like standing water and, you know, and the nets, et cetera. Have you worked around education and development of community sort of appliers, community, you know, mediators of really long-term change? Is that something that's part of this project?
Right. I did not get a chance to work in that level because I mostly worked with the research institute, but there was an institute who was actually implementing the project that they got money from the Global Fund. But that is very important when the behavior change communication, there was money for that, but I was not directly involved with that.
That's fine. I didn't mean that you personally. I guess I said it wrong. I meant, was the effort, did the effort involve that? So
right. But what my findings was directly communicated with the program implementers who really like that. When I published something, they told me that, okay, you can come and give a seminar, we can learn from that. We can learn the next step, next strategy. So my research support was rewarded. In that way that they like that and they wanted to implement to improve the community's health and implement the program. It was a large money because they got $44.7 million.
I have one question, Rick.
Please.
And you know, and let me just preface my question by saying that I'm not an expert on climate change and, you know, impact. So, but I think you raised a great point with respect to the impact of landslides on other healthcare outcomes. So are there, and I don't know the answer to this, are there differences in the patterns of infectious diseases that arise as a result of these changes with respect to landslide vis-a-vis flooding or other things? Because, you know, typically we associate flooding and other things with increase in either vector-borne illnesses or, you know, diarrheal illnesses, et cetera. But is there something different in the patterns that emerge after a landslide? Or do we not know that?
But definitely there should be some impact. That is true that after the landslide, after the flooding, after the complex natural disaster like hurricane, landslides and flood, when it happens together, there should be outbreak of infectious disease like malaria or dengue. That is perfectly true. That is a very strong hypothesis. And I strongly believe in that, but there is no study so far on that. But I'm pretty sure if you go to Indonesia, if you go to Southern India, you will see some kind of pattern like that.
Oh, I know. I'm from the South. I grew up in India.
Right.
So yeah,
Southern
so
India,
I know. Yeah.
or even Sri Lanka.
Yeah, the associations that could come from this, or predictive associations, are very interesting, and getting into the computing capability to do that, which I know that Ubaidul is very interested in expanding that.
Right, because then if you had computing, if you had that kind of AI and predictive modeling, then you could alter interventions or target interventions to select areas versus the other, because at the end of the day, everything costs money. So kind of looked at cost effectiveness, in certain areas versus the others based on emerging infections or prediction of emerging infections would have a big impact, I think, down the road.
Right.
Thank you.
You're welcome.
Great. Any other comments? I see we're at the top of the hour, but you can see how I was excited to have Dr. Hake present really some of his work and some of the planned work that's ahead. And so we thank you for the time. Folks have to run now, but thank you so much, Dr. Hake, and for showing us your work. And we applaud you. So thank you everyone for coming, and we'll wrap up this seminar. And again, it's recorded for those that missed it, and they can get it on our website.
Thank you.
Thank you very much, and good luck, Rick.
Goodbye.
Yeah.
Thank you.
Yes.
Thanks, Shobha. Thanks, everybody.
Thank you for having me.
Great.